All right, great. So here we are. We're doing the talk, right? So
We're doing
really
the
appreciate your time coming in to talk about a subject that is extremely, let me put it this way, very dense, perhaps, a very broad swath of issues that come up with people with this. So in this episode, we're really talking about tendinopathy, and so we got a lot to talk about. Probably won't get it all this episode, though, right?
Not even close.
Perfect. Okay, so let me start things off. So Dr. Sliva is with me today, and she has a lot of training around this type of thing. So she went to residency for family medicine, did a family medicine residency, and that was at Spartanburg Regional Hospital in South Carolina, right? And then she went on and did extra training in sports medicine, did a sports medicine fellowship at Wellspan Hospital, and that's in York, Pennsylvania.
It is.
Correct?
Yeah.
Okay. And then right now, how long have you been in practice, by the way?
So this is going on year 3 now.
Year 3.
Yeah.
Okay,
Rookie.
perfect. Yeah, but no, it's like the perfect time. Like
Yeah.
you got your way of doing things
Yeah.
and all that stuff. But currently in your practice, you see patients, really a wide range of patients from just normal people, perhaps, all the way to weekend warriors and college athletes. And the one thing that I think is great about your practice is actually you use or extensively use ultrasound.
I do.
Okay.
Yeah.
And that's really pertinent to what we're about to talk about today, right?
Yep.
Okay, perfect. So the first thing that I noticed when I was doing the research for this episode was just how common tendinopathy and tendon problems are.
Yeah.
And so 2 big numbers come up. The first is 50% of all sports injuries are related to tendon problems.
Oh, yeah.
Does that sound correct?
It's 100%. I mean, I hate to throw another percent out there, but yeah, I mean, everyone complains about this has been going on for months, but I didn't do anything. I swear, doc, I didn't do anything. Yeah, I believe you. That's mostly how it starts off.
Right.
Yeah.
Yeah, big percentage. And then the next big number that I saw was that it's about 30% of all primary care visits
It
to the
is.
clinic, which seems like a huge number.
Massive number. I mean, I remember on our family boards, it was a big thing was 30% of our test is ortho. It's sports medicine. And that's the big reason why. The knee pain, the shoulder pain, the foot pain. I mean, before we refer over to the specialists, they come into our office.
Yeah, and it's just like the volume, it's almost like it's an epidemic, honestly.
It is. And I mean, everyone has their own personal theories on it, but I mean, we're active. I mean, the body moves. And whenever it doesn't move correctly, we start seeing the problems, right?
Yeah, definitely. I'm actually going to ask you about that a little bit, about like the compensatory movement patterns that occur because the joint starts hurting, and then you start moving the joint abnormally, which creates its own problems. Snowball. Yeah, perfect. Okay, so let's start things off. So give me, as best you can, a quick 1-minute answer of what is tendinopathy.
It's a catch-all term. It's the umbrella term because we hear and we see different things getting tossed around. We hear tenosynovitis, we hear tendinitis, we hear tendinosis. What does that all mean? What is that? I think of it more of a spectrum, and the catch-all term is going to be tendinopathy, a problem with the tendon, right? Break it down to the basics of the word. It's a problematic tendon,
Right.
And that's what it is.
And you brought up the term of spectrum, right? So it starts off as like a little something. Like a little inflammation maybe.
Yep.
And then it moves on from there.
Yeah.
Talk a little bit about what that spectrum is.
So I mean, I lovingly say we treat people, not pictures, and not labs, right?
I love
that. I mean, that's our job, is to manage the patient. So initially, a lot of people are asymptomatic. So it's not even on their radar. So whenever patients come into us with this, they're already symptomatic. They're now being hindered on being able to do what they want to do. Activities, life activity, work, or they're limited by it. But it starts off asymptomatic. Then it's going to be this achy tightness first thing in the morning. And then you get our adult weekend warriors or occupational athletes are like, oh, I'm just getting old. You know, we hear that all the time. Oh, I'm just getting old. It's fine.
And then now they're my age, and I'm like, well, I don't think you're that old.
Right. They were looking at it like, no, my friend, we're peers, and I don't see myself as old.
Right.
But even with our younger athletes, and then their parents are like, no, you just trained really hard yesterday. It's fine. So it just gets pushed off. But then it starts evolving. Now it's not just in the morning or after you're sitting for a while feeling all stiff, just need to warm up a little bit. Now it's during the activities. Maybe not at rest yet, but just during activities. And it's lasting longer. It's getting worse. It's more pain. And then it starts happening at rest. Now it's affecting my sleep. Now we're going to go see a doctor. Because whenever the sleep gets affected, problems.
Yes. I see that a lot too.
Yeah. It's like, okay, I get you. And that's usually how it presents. And they rack their brains going, they're trying to be their self-detective, right? What did I do? I must have done something here recently that caused all of it. Usually not.
Right. Yeah, I think the sleep point is a great point. Once people start losing sleep over it, so to speak, right? Then their quality of life can really go down.
Yeah.
And so that's like kind of the early phase of things, right? So it starts off, maybe you feel something, or actually you don't feel anything, you said.
No.
And then it kind of feel a little bit of something, and then it gets worse, and so it's like accumulates over time.
Builds up. It just builds up. Especially I always think of our occupational athletes, and I think of our athletes a lot whenever we think about this, because they start modifying what they're doing without even thinking about it initially. Our bodies are clever.
Right.
They're going to find a detour. They're going to find a cop-out to be able to get around the problem and still be able to function.
Yeah. Okay, so in that early phase of things, I guess this gets into a little bit of the pathology, right? So maybe let's talk about the pathology of that early phase.
Yeah.
So what starts happening early on?
Yeah. So anytime we stress our body adapts to it, right? So it's always evolving. It's always changing to what we're doing. So the tendons are going to be stressed whenever we're doing activities. And so there's going to be a turnover. It's going to be, the collagen's going to be replaced. It's going to be strengthening along the process, but that takes time. There's steps to that, and that involves inflammation to get everything going. I mean, inflammation is intended to be a proactive until it's not.
I gotcha.
Right?
So so that normal balance is a term I hear a lot. The normal balance of a tendon. You're using it.
Yeah.
And it requires maintenance.
It does.
And so you're using your tendon, I'm using my tendon, and then the little fibers that make up the tendon, they get a little worn out.
Yep.
But the balance is that your body can replace those fibers with new fibers of equal quality, equal strength. Is that kind of does that sound about right?
Yeah, and
like maintenance.
Right, and it's not like a one-to-one exchange, right? We take out the bad and we put in the new. No, there's steps along the way, and that's when things get bobbled. And this is a very elementary way to think of it, but I think of if you don't give the body time to do it, it almost stumbles over its own feet, and it just gets backlogged. Another way to think of it is I Love Lucy, whenever they're at the chocolate factory and they get all the chocolate backed up and they're making a huge mess.
Oh, right. You mean on the conveyor belt?
The conveyor belt.
No, I
and
actually like that.
Like backs up. So
the chocolate's like the worn out tissue.
Yeah, and it just accumulates. It accumulates and it becomes problematic. And that's where pain starts happening. That's when we start. If you take a look at images, that's when you can start seeing the changes of the tendon, morphology almost of it. It becomes thicker. If you look under ultrasound, a beautiful tendon is linear fiber.
About linear, you mean lots of parallel fibers perfectly lined up.
Yeah, they're lined up. They're like straight lines. It looks beautiful. But whenever you start seeing more chronic changes, it loses that effect. It doesn't look as uniform.
Right. Yeah, that makes sense.
So, and that's where we can physically see, like, okay, it's there. But again, pictures are nice, but we again, we treat patients.
Right.
So it's an aid to be able to look at that.
Okay. Yeah. I love that. I love those descriptions of that. I think that is really helpful. So does that take us through kind of to like the middle phase of things? Like, okay, I have some symptoms. Maybe I'm getting some wearing out of this tendon. I'm not replacing some of the good components of the tendon. And we're starting to get into the more what we would call chronic phases of tendinopathy.
Yeah. Once we get into chronic, it's almost like a non-productive inflammation. It's just happening. It's just hurting at this point. So the challenge is how do you, as providers, figure out how to manipulate the physiology?
Yeah.
How do you snap that? And that's where you can fall down that rabbit hole of like, what are we doing? Like, how do we do this? And that's where the treatment and talking about that goes. And we're trying to, that's the goal of the treatment, I guess is what I'm saying, is trying to correct that healing process and try to promote that healing.
Restoring the balance.
Yeah, restoring the balance.
The balance of, okay, we're catching up on the conveyor belt with the chocolate.
Right, exactly. You know? And it's interesting because we're like, okay, just rest it. Yeah, tendons don't like rest.
Yeah, true.
They're workhorses. They prefer work. They heal better with work, but how much is too much? And that's where it gets you're walking on that thin ice and doing a balancing act with the treatment.
Perfect. Yeah, that's excellent. So, okay, let's touch on this briefly because I think this will help patients understand everything. So, let's go back to anatomy for a second. So, can you tell or describe what like tendon structure is?
Yeah. So tendons, it's a rope. You keep it simple. It's a rope. It's a rope with different little ropes inside. So, I mean, if you look at an actual rope that's on a pulley, if you really look at it, it's individual little threads that are then twisted around and then make the stronger rope that we use. Okay. So it's made up of collagen. So that's that strong tensile, soft tissue that we think of that makes the tendon what it is.
Those are like the little fibers.
Yeah, those are the fibers. That's the bulk of it. I mean, that's his collagen is the headliner of the tendon. But we got to have blood vessels. We got to have nerves. Hence why you hurt, because nerves send you the message.
Right.
But you also have these things called tenocytes, which are kind of the ones that play the quarterback or the manager on site that help with the process of the healing and the turnover and adapting to the stresses that are placed on it.
Right. One of the things, perfect. I like the rope description. One that I've used also for like the blue collar guys, they're out there doing labor stuff, is the maybe like a fiber optic cable or like some sort of conduit, like a pipe with a bunch of smaller little cables. They're all running together in parallel.
Cables, yes.
And then if you just cut it, you see all these other little fibers in it. So that's kind of
spot on. That's
perfect. It. And then in between are those in between all those fibers, those tenocytes are all kind of scattered in there.
Yeah.
Okay. And those so they act like little sensors, right?
Yeah, they're sensors. They're kind of, again, they go, okay, we need to repair, we need to strengthen. That's kind of their job, to get things going and initiate the process. So they have a huge role there with the healing process of the tendon and the health of that tendon.
Right. So sort of the way I thought of it was, I guess just like a little sensor. They sit there and they can feel, maybe, maybe this is a very, I'm sure there's some like PhD scientists out there that will get really angry, but they sort of can sense the tension across the fiber. Yeah. And then they can, and that tension, when they pick up on that tension, they produce more collagen. Yeah. Or they initiate
that process of more collagen, because it's not just okay, tenocytes activate.
Yeah, sure.
Yeah, exactly. We're gonna go superhero mode.
Right.
Like, but no, it's more. There's several steps, and without diving in and taking us all the way back to med school, and going back to physiology class, but there's steps. So the type 1 is our big collagen. There's several different types of collagen, but type 1's the big one. That's the one that's healthy. But whenever there's an injured area, the tissues get eaten up by our macrophages. I mean, that's our cleanup crew during the inflammation process. Got to get the bad out before you can lay down the good. And then I always think of it as scaffolding. The collagen 3 just is haphazardly placed. It's like just patchwork. It's just like, okay, just hang there until we can get everything handled.
Right.
But again, this takes time through the inflammatory process and all the components of that. And there's so many different pathways involved in it. Again, rabbit hole of that healing process. But during that healing process, it converts from type 3 to type 1, which is that nice linear rope-like uniformed collagen. But there are times where that conversion doesn't complete, and that's where everything gets a little bit jumbled.
And that process that accumulates over time, that's when you get chronic tendon changes, chronic tendinopathy, chronic pain, and then that's when they start heading over to my clinic because they start having partial tears or even complete tears of the tendon, and then you start maybe heading into a surgical type of situation.
Yes, exactly.
Perfect.
Yeah.
Okay, so we did talk a little bit about how symptoms present. I think this is really pertinent. Let's go back to the compensatory movement patterns for just a second. So my joint hurts, so the initial thought is, and everybody, and it's not necessarily, I can understand why they might want to do this. I'm not going to move this because this hurts.
Right.
And then problems happen.
Right. I mean, it's I with patients, I go, it's not your fault. It's nothing you did wrong. Lizard brain took over.
Right.
And just handled it. Your body was like, it hurts. Pivot. We got to change our plan, and let's do it this way so we can still get the job done. You didn't have a say in it consciously. The body just handled it.
Right.
But that's the problem. You're recruiting muscles in different structures to overwork in a way that they never were intended on doing.
Right.
So the big ones that we see are shoulders, rotator cuff tendinopathy. All of a sudden they're coming in. No, it's not my shoulder. It's here, pointing to the upper trap.
Yes.
Instantly, it's all about shoulder elevating and shoulder shrugging versus abducting to get that going with that supraspinatus. It's like instant. And now they're having headaches, and now they're having neck pain. And I mean, again, that's snowball.
Yeah. Perfect. That's exactly correct in my experience, in my practice. So the trap pain. So it kind of hurts here, but then it hurts here. Hurts here.
Yeah.
And then it like hurts here.
Yeah.
But then the source of the pain is like here.
Yeah.
But then everything hurts.
Right.
Yeah.
So one of my favorite questions is like, one finger, one spot. Where does it start? Where did it start? I understand it all at places.
I use that too.
Where did it start? That's why I need to find the origin.
Right. Yeah, I definitely use that.
Yeah.
It kind of helps, when somebody's been dealing with this for a long time, like everything hurts and you don't even know where to start sometimes, unless you kind of like, you really have to kind of sit down, take your time with the patient and kind of like figure out where did it start, and then understanding what those compensatory movement patterns are, and kind of like maybe like work your way back a little bit.
Yeah.
If you have
And it's the buy-in, right? It's like, okay, I hear you, I got you.
Right.
But I need to bring it all the way back. All the way back. There's a lot of things, and I think, and I tell them, I'm like, I think this is a snowball. I think there's a lot of different things, but I got to figure out who started it. Who is the instigator?
Yes. Agree. One last thing to add from my you see this too, I'm sure, but not only do they get muscle pain, and when I say muscle pain, other muscle pain, that's not the muscle attached to the tendon, but they will get a stiff joint.
Yeah.
So, and for the shoulder in particular, they'll come in with a frozen shoulder or adhesive capsulitis. They can Google that. Adhesive capsulitis. The shoulder, because it hurts to move it, they want to move it less because that sort of makes it feel better. But then what happens is the joint gets stiff. And then not only do you have muscle pain, but now you have a joint that's so stiff you can't even move it. And that can lead to all sorts of diagnostic problems because and then they end up with like an MRI or something. The MRI shows very little something, little minor this or that.
Yeah.
And then if another doctor or clinician or somebody's not kind of thinking of the whole picture, the next thing you know, you're like scoping their shoulder and chasing some tiny tear, and then that'll make everything worse. So you have to be really careful of this. That's the first thing in my mind is like, okay, I don't want to make this person worse.
Right.
Like, you kind of, but you can see this pattern over and over again.
Yeah. Yeah, it's education, right?
Yeah.
And it's just talking it through with the patient and go, I understand, I get it. It's just, we just got to put our to-do list down.
Gotcha. Can you talk a little bit about some of the other associated medical problems that can pop up or that might make people more predisposed to having tendinopathy?
Yeah, tendinopathy, it's interesting if you dive into the literature and everything. It's like, well, there's got to be risk factors. Well, there's intrinsic and extrinsic. There's modifiable, non-modifiable. So, I mean, the basics are overuse, poor and without rest. Okay, those are the classic athlete symptoms. Okay, that's a risk factor. Our occupational athletes, same story.
Maybe like the same repetitive motion.
Yeah, so think
over and
of
over
your
again.
construction workers who are doing the same motion over and over. I think our overhead athletes for your rotator cuff. Think of anyone that holds a hammer for lateral epicondylitis.
Right.
Any of that type of stuff, or even with tennis players hitting the forehand shot over and over. Another ones are think of your more chronic conditions, diabetes, any type of thyroid issues. There seems to be a connection. I mean, more with adhesive capsulitis. I mean, those are
those kind of more classic
huge risk factors. But I mean, there's those are pro-inflammatory type conditions. Rheumatoid, pro-inflammatory.
Right.
Things that, I mean, that's what it is, right? If you think back to the physiology of what we were talking about, we're talking about inflammation. So if anything that really just encourages inflammation, it already puts you 2 steps ahead of the rest of the population with inflammation.
So maybe like starts things off because inflammation, once you get into the more chronic phase, it's not as, perhaps there's some inflammation, but it's not like the main driving thing.
It's not what we think of tradition inflammation. It hurts, it's swollen, it's red. Usually when you get to the chronic, it's not so swollen anymore. It's not like that soft bogginess that you get, like you bumped your knee and your bursa blows up, or like it doesn't have that component to it anymore. But it's chronic inflammation. It's another animal. It's odd. Right. It's an oddball.
Yeah.
It's an oddball.
Yeah. There's a lot, like you said, there's a rabbit hole here, which is, we'll save it for part 2 of this, I guess. But the, just going through all the, like the cellular, molecular stuff, there's this, new, nerve ingrowth into the area that's very, that creates sensitivity and stuff. You got different neovascularities that develop. Again, this is the whole package, because whenever you have inflammation, you got to get blood there in order to help with, you got to get the products there in order to clean up and build. So there's neovascularity, or new blood vessels or capillaries that start growing within that region, peritendon or within the tendon. And that's what's interesting. You can see those on ultrasound whenever you throw the Doppler on. You can see the little, the red stars, if you will. And then new nerve endings and you have your neurotransmitters firing a little bit more.
So think of substance P and your glutamine. You know, it's like those things that trigger.
Yeah.
The physiology.
It's I guess it's just when the tendon gets to that point, it just wants to send out more pain signals to you. That's kind of like maybe how I might think of it.
It is. It wants to tell you to knock it off. I mean, pain is a message to your body to leave it alone. It hurts. It's in trouble. You need to rest it. And yeah, to an extent.
Yeah.
You need to modify what you're doing. You need to do the activity modification. And again, that's one of those elements of how do you treat this.
And by the way, when you say activity modification, you're not saying
lock it up.
Don't move it at all.
Don't throw your arm in a sling.
I just want to make sure that.
Don't throw your arm in a sling and not use it again. No, because then we're going to go back. Yeah, please don't do that.
Right.
Please don't.
Okay, a couple quick points. So, have you come across anything about elevated cholesterol? Obviously, it's very prevalent.
Again, hypercholesterolemia is pro-inflammatory.
Okay, so that's kind of the thing.
Pro-inflammatory. It's. I mean, there's an. I think there's all of these elements of trying to figure out how we can reduce it.
Without going too far down the rabbit hole with this, when you see somebody whose cholesterol is like really high and they're coming with a shoulder problem, are you concurrently treating that? I guess you should treat it anyway, maybe.
You should, but here's the caveat. What do you treat high cholesterol with?
With a
statin. Guess what statins do?
Yeah, makes yeah, interesting. Yeah.
Yeah, so again, it's kind of like, well, shoot. Well, shoot.
Yeah.
Where do we go?
Yeah, I guess that's the diet.
Yeah.
Right.
Yeah. We got to go back to
easy fix.
The body is a closed system. What we do is throw wrenches into the system and understanding that we're going to probably create a new problem.
Yeah.
Okay. I mean, think of all the medicines and we talk about the side effects. Anything we throw into the system, we're probably going to mess something else up.
Right.
Not a whole. And the idea is very little. Very little, minimal. And that's where we talk about it during the treatment options.
Right. And then finally, like fluoroquinolone, antibiotics.
Yeah. Speaking of medications,
that class known for causing tendon problems. I spoke to an infectious disease colleague of mine and asked them about the tendinopathy caused by these antibiotics, fluoroquinolone. So like levofloxacin, ciprofloxacin. So maybe look on your bottles and see if you have that. But if they start having like joint pain, then the infectious disease physician told me that they would just tell them to stop, and then I guess they're gonna have to figure out another type of antibiotic to cover.
They find another option. I mean, it's pretty. In my training, and the buzzword was with kids.
Okay.
Kids is predominant, but again, it's something to monitor, and this is where that patient education comes in.
Right. All right, so let's move on to imaging. Okay, so X-rays, right? Maybe just a general good survey of the joint.
Yep. I mean, sometimes you can see something. Calcific tendinitis. You can see that calcium deposits on it. You can make some infer a little bit on what you're seeing, what the bony changes are, especially on where the tendons attach. That's where your anatomy comes in. It's like, where do these guys originate? Where are they going? And you can make some assumptions. I'm not going to give you a hook, line, and sinker, but they can sometimes give you a little insight on what they.
So definitely a good first step. I get, patients ask, why do I need X-ray? It's not going to show a tendon. So why are you going to do an X-ray?
Yeah.
So I guess just that education on, I can infer certain things. Yeah. We can make some educated guesses.
Yeah.
That helps them understand why they're important. Yeah. Okay. So let's talk about ultrasound. So I'm sure one of the things you love to talk about. So what's so great about ultrasound when it comes to talking about this stuff?
Yeah. So what's fun is that one, it can be dynamic. I can actually see the tendon move. I can have, let's take a knee because the patella tendons are really easy tendon to see on ultrasound. And you can actually see that thickening on the deep side of that tendon where it's going towards the fat pad, Hoffa's fat pad, and right at the insertion at the kneecap or the patella. And you can see that thickening in those changes on there. You can see, and again, there's a setting that you can turn on to see the blood vessels, and I call them stars because they flicker like stars. Little red dots within that swollen area where there's neovascularity. And you can compare it to the other one without having to order another MRI. You can compare it to the other one very quickly in the clinic, and you can measure the thickness of that tendon and go, yep, there it is, clear as day. That's a way that you can see it, and you can appreciate it a little bit more. You can sometimes see, depending on the severity of it, you can see partial tears and with the changes of the tendon of it. It's just a nice guide you can utilize for a quick evaluation there in the clinic. It does not take long to evaluate
and
them.
It doesn't hurt.
Doesn't hurt. In fact, they get a little moisturizer because the gel has a little aloe base.
So I was listening to one of the lectures you sent over to me last night, and the presenter mentioned something called microanatomy, which I'd never really heard before, but it makes a lot of sense because there's gross anatomy, I guess, where you can see it's just a tendon. You just see a big, thick cord of something. But there's actual important smaller bits of that anatomy that you can actually see on the ultrasound, the fibers and things like that, the fiber orientation. And you can even see that disorganization of those fibers that we talked about earlier, right?
Yeah.
Okay.
Yeah. So again, it goes down to the cellular level that we're working on.
And you don't always see it. You can see a little bit maybe on an MRI, but not like that super fine detail.
Not that detail, not to that magnitude, I guess, especially on really good ultrasound machines. It's like you can get some detail.
Perfect. So ultrasound, you can get all that nice detail. You can actually see the tendon move, which is really cool. Patients like it. They can watch it at the same time. And then in terms of like treatment, you even use it with treatment, right?
I can.
Yeah.
So let's talk about it. I mean, with ultrasound, we can use various different types of injections. The one everyone thinks of, the one that we lean on a lot, is corticosteroids injections. Put it out there, tendons don't love steroids. It can make them weak, can actually hinder the healing. So I tell patients, like, this is not going to fix anything. This is, especially with like subacromial injections for your rotator cuff injections. We do them. It's common practice, knowing that we're not doing anything to fix it. We are just pain managing. And a lot of the research has shown that you're going to get temporary relief. I mean, there's good findings that you'll get temporary relief, a couple weeks. So that's patient satisfaction, check. But long term, and that's what we're going for. I love my patients, but the idea is not to have them coming in year after year for tendon problems or months after months of discontinued tendon problems.
Right.
So that's one. There's also plasma-rich protein, which is PRP, which is a common term thrown around. That's fairly new-ish in medicine world. In ortho, we utilize it. The idea behind that is because there's no natural heavy vasculature to tendons, is let's take the plasma and inject it into that area that has that pathology to help with the healing process. That's kind of the idea of it.
Right. And so when you use ultrasound with that, what you're doing is you can find that precise anatomy with the ultrasound. And with 100% precision, actually, and I use this term.
Watch it.
Right. With 100% precision, you can put the medication exactly where you want it.
Yeah, exactly. Because I can
Hugely
watch that
beneficial.
needle. And I can watch that needle go right to the problem.
So if I see patients, they come to see me, maybe they've seen somebody else, and they've had an injection, and that's helpful to know. But what's even more helpful is where was it given, and if it was done under ultrasound, then I have a little bit more confidence, maybe a lot more confidence that the shot actually went to the intended target. Because if my shoulder hurts here and I had a shot that was done by feel, okay, some people are good, but an honest person is probably going to say, I probably have a miss rate. And they had no response to the injection, bathing the area with a local numbing medicine. And they don't get any better, even for like a brief period of time. You're like, okay,
clearly that's not the problem.
They're not right. They're not hurting here. So the ultrasound, I think, is just a great way of doing things.
It's again, it's an easy tool to be able to ensure needle placement. And just with the years as it's advanced, it's just gotten a little bit easier and easier to utilize that tool.
Definitely.
Other ones are like stem cell. That's another one that they're doing. I don't do it in my practice, but that is showing promise too. I mean, if you think about it, using that stem cells, it can basically check into work as a utility player.
So
and just kind of fill in.
In the orthopedic in the orthopedic journals, I feel like they try to steer people away from the term stem cell.
Yeah.
And use the term signaling cell.
Yeah.
They put in a cell that's not a stem cell. It doesn't mean that it can turn into anything it wants to.
Right. It's just an unlabeled cell.
Yeah. Well, it can say, hey, stem cells come here.
Right. It can help out with that too. Yeah. And again, is it purely stem cell? No. Let's be really clear. It is not pure stem cell or just like cell mediator signaling. That's not pure. Yeah. It's a package. And that's what also needs to be understood. And that's where the controversy comes into play with like dosage and how much. Because we don't know yet.
Yeah.
We're still working on it.
Yeah, for sure. So I guess it's promising.
It's promising.
But the biggest downside to me is, it's extremely expensive. Nobody pays for it. It's and patients don't necessarily want to put themselves in financial stress for a shot that is not. And
it's right now it's 50-50.
Yeah, maybe not. Yeah.
And quite honestly, even with the research that I came across preparing for today, all of it is coupled with physical therapy.
Right. Exactly.
All of it.
Perfect segue.
Let's segue.
Let's talk about the PT, the exercise, the physio. Okay, so what role does that have when treating this problem, tendinopathy?
It has to be done. This is where, when I was talking, tendons are workhorses. Tendons want to work. This is where they can, under a controlled environment, place tension on the tendon so it can repair itself and adapt. So you got to put tension on that tendon in order for it to heal. And that's where physical therapy comes into play. And there's a bunch of different ways that you can contract a muscle that's pulling on that tendon to get it to work. And I think it was in the 80s or 90s, eccentric loading was like all the rage. You got to eccentrically load it, and it still is. Let's not question that. Eccentric loading is still a big component of creating that tension for that tendon.
So eccentric, there's strain. So real quick, what's eccentric mean?
Eccentric is elongated. So think of like you feel like you're going to a stretch, but you have a load. So so the tendon is being pulled under weight. That's the best way I can describe it.
Right. Okay.
Yeah. Versus concentric, where I always think of biceps curls as like bulking up, real short, quick contracting. So you're pulling the weight up.
Gym bros. So gym bros, it's the negative.
It's the negative. Yeah. There you go.
Yeah. My curls here, I'm lowering it down.
Yeah.
That would be an eccentric, right?
That's it.
Okay. All right. So okay. Sorry. So loading the tendon is what the tendon wants. And it's what stimulates reparative response.
Yeah. And then, but there's a limit. Too much of a good thing is no longer a good thing. So there is a balance.
Yes.
And this is where your physical therapist comes into play. There is, you want someone to be guiding you through that. And that's why I'm like, home exercises, they're lovely. They are, but you need to know what you're doing. And that's where I need you to go and see a physical therapist, have that guidance to go through that properly. Because if you're doing too much or even too little, you're not helping yourself. So there is that tension curve, stress and tension curve that you have to take in consideration. The physical therapist will guide you through that. But there is a little element of pain, and that's something that needs to be talked about whenever we see patients. It's like, this is not going to tickle. This is not a warm, fuzzy blanket. There's going to be a little bit of pain associated.
Yeah.
And it's like, you're laughing, but I mean.
No, it's true. It's very true. And I actually see this in post-op patients as well, where say they have a big rotator cuff tear, I fix it. The tendon is healed technically, but the tendon still has tendinopathy finding. You know, it's like I'm not making the tendon 15 years old. The tendon's still 65 years old, or still has that process going, but the tendon is now healed. It's in continuity, and then patients can come back, have similar pain. The tendon is healed, and they've stopped doing their maintenance program, and so their symptoms have recurred.
Yep. Welcome to it.
Very common.
And I tell people, I'm like, this is a process that is a marathon. This is not going to get fixed in 2 weeks. I lovingly say I don't have fairy dust, magic wand, or a magical bean that's going to make this go away in a couple weeks. This is going to take months. We're talking, I will see you in like 2 months, 3 months, but I'm only expecting about 50% improvement. Real talk. 50 to 60%. That's all I'm expecting in that time. And that's with physical therapy and doing your home exercises along with that your physical therapist gave you. This is a long process. Remember, your problem started a long time before you started having symptoms. Months, years. Hard to say. I don't have that time machine to be able to go backwards, right? So you have to understand it's going to take a long time to recover. I mean, depending on what literature you read, it can take up to a year. And that's with dedication. So I tell my patients, like, you'll be discharged. You'll graduate from physical therapy, but you didn't graduate from the exercises. It will come back if you don't keep up with it.
Yeah, absolutely. And not only are you trying to load the tendon and just load the tendon, but if you've developed those compensatory movement patterns,
we got to correct.
And your joint is stiff, you have to correct the joint stiffness, the muscle tightness perhaps that's developed, and you have to load your tendon. So it's like all these things together to get better.
And again, this is a huge thing, and I think medicine is gravitating more to the patient buy-in and really making a collaborative effort. And again, I even tell patients, like, knowledge is power. I'm like, I don't ask you just to do things just for the fun of it. Let me explain the why. Why am I asking you to do this? Why am I telling you that this should work? I don't ever say is going to, because that's a promise I can't make or keep, but should work. And this is the reason why. And it's that dedication, and it's figuring out how are you going to do it. I'm not going to shadow you around. Your physical therapist is not going to shadow you around. I need your buy-in. I need you to find that dedication to it.
Do you get a lot of looks when you suggest therapy still?
I do. And I go, don't judge it yet. I go, don't judge it yet. I go, here's the thing. There's a lot of different other modalities they can utilize. A lot of it is still kind of like plus minus in it. Everywhere you look, tendinopathy is an individual journey. Everyone's journey with tendinopathy is going to be a little different. What their treatment's going to be and what is going to be required for them is going to be different. So don't write it off, because there's dry needling that can help. There's electroshock wave therapy. There's laser. There's ultrasound. There's a lot of different modalities that in physical therapy they can utilize. These are options, and you may need to use the whole spectrum to supplement and adjunct to the therapy that you're getting.
Yeah, I definitely, maybe less so than I used to, but I definitely still get looks. And a lot of those looks come from guys that they're strong. They do a heavy duty job, and they are strong, but and so when they get the hey, you need therapy to do this, they're like, this makes no sense to them.
My favorite is Gluteus medius tendinopathy. My favorite. Because when I get them to do hip flexion or hip external derotation, they can't beat my two little fingers, and I just drop. I go, so about that strength you say you have.
Right, exactly.
It's like you just boosted my ego, and that's not okay.
Right.
It's like this is what's not being focused on. It's like, keep going to the gym. I want you to go to the gym. Use pain as your guide. If it hurts, back off. But I need you to go to physical therapy. I need you to pay attention to the less showy muscles.
Right.
Okay.
Right.
The guys that don't get the attention but do all the work.
Yes, exactly. The ones that hold you up.
Exactly.
So I want to bring up a couple things that I learned. from some of the information you sent me that I thought was really, really helpful. And it'll be super helpful to patients. I'm going to probably use this line at least 10 times today when I start clinic. So, quote, moderate tendon loading is anti-inflammatory.
Yes.
Who would have thought?
Again, tendons like to work.
Yes.
Put them in the environment they're comfortable in.
Yes. I can't say that. I'm going to say it one more time. Moderate tendon loading is anti-inflammatory. And of course, as we said, regenerative. Mm-hmm. And what you said earlier about it can't be too little, it can't be too much. So true. Yep. So statistic. So this is a little bit of laboratory stuff, but in the lab, in this particular study, they loaded the tendon, I guess 4%, which means it elongated by 4% of its resting length or something. Yep. And if they loaded it just at 4%, that was enough to create the anti-inflammatory response. Mm-hmm. But if they loaded it to 8%, it was detrimental. Yep. So there is this sweet spot for sure. Yep. And that's why we need the supervised therapy, or at least lots of education, and then the patient can do it on their own.
Correct. And again, it needs to be emphasized. It's not pain-free. Mm-hmm. It's not pain-free. You need to have something there. You need to feel a little work. Mm-hmm. But I'm not asking you to go into a place of tears. We're not trying to do medieval torture here. We're not on that stretching device, okay? Right. That's not what we're going for. It's moderation, Goldilocks.
So yeah, absolutely. And so when I read this, I was trying to figure out, okay, nobody knows when they're stretching their tendon 4%. So I came across some studies that use the visual analog, or was that what is the visual analog scale?
Yep.
So essentially, for those who don't know, it's essentially a scale 0 to 10.
Yep.
And you might have seen the little smiley face, and then it gets I'm not so happy face, and then all the way at the end, like I'm crying face. So on a scale of 3 out of 10, the patient's own perception was what the studies that I read had used to know when you're doing too much. Mm-hmm. So go to pain about a 3 out of 10, and you're probably or hopefully within that ballpark where you're causing an anti-inflammatory effect and a regenerative effect.
Yeah, it's like where you go, okay, I'm feeling it.
Yep.
And not to the point like, oh my goodness, stop.
Right.
Clearly that's like overshooting, but it's okay, I'm feeling it. It's not horrible. I might be a little nervous to keep going.
Yeah.
It's that warning place that you need to take into account.
Critical. Yes, critical. Okay, so you mentioned, how long do we have to do therapy before we start feeling something?
Yeah, I tell people therapy, I tell people 8 to 12 weeks. Mm-hmm. And again, when you come back and see me around then, I'm not expecting world changes. Mm-hmm. If you come back 100%, great. Love it for you. Great, wonderful. My expectation, though, 50 to 60% improved.
And then it doesn't stop there, right? This is, so there's active measures where you're actively participating in your own treatment, and passive measures. Right. Tendon problems, tendinopathy, it's not like it's not like you got to take a pill for your high blood pressure and your blood pressure comes down and then you're done for the most part. You have to be very active in your own treatment.
This is a very dynamic treatment journey. Yeah. It's not to be idle at all.
Right. Okay. So we'll touch on injections, and that's probably all we have time for. Yeah. But so we talked about cortisone shots, and that they really only help with pain. They don't change what's happening to the tendon, correct?
Nope. In fact, I mean, if you think about it, it might even be hindering the healing process based on what cortisone does.
Right.
But again, I tell patients, it's like, sure, we can do it. Here are the risks. It makes tendons weak. There is that unlikely but real chance of rupture. That's why I will not do it on certain high tension tendons, Patella, Achilles.
Right.
Don't ask. Not going to do it. PRP we'll talk about, but in cortisone, no.
Right.
Yeah, and again, it's pain. It's to get you, help you through physical therapy, is the help.
Yeah. How many shots will you, if somebody comes in and how many shots will you give them? Cortisone?
So, like, if we're talking like subacromial, that's a big one. I tell them, it's like, I want this to be a one and done.
Same.
I don't want to do this again. That's the goal. I'm trying to, I tell people, I'm taking that metaphorical bucket of water and throwing it on the fire. That's what I'm doing. I am simmering it down.
Yeah.
That's all I'm doing. I'm not fixing the problem. What's going to fix the problem is fixing the mechanics of how you're moving and loading that tendon with physical therapy. That's the fix for this. Right. So that's the idea. I try not to repeat them more than twice a year. I really try to encourage other ways to manage it.
Agree. That's exactly what I do. I try to avoid it at all cost. We didn't really touch on like MRI findings necessarily. So I'll do that real quickly. The biggest benefit to me on MRI is there like a bigger tear?
Exactly.
So that we know if somebody's not getting any better, do the MRI, make sure that there's not a big tear that we just got to deal with.
Right. That's half the benefit of having them come back at that 8-week mark. If they're not noticing any strides in improvement, let's go. Let's go find out there's a significant tear in there.
Yeah, just make sure. Yep. And so that would be a situation where I really try to steer people away from a cortisone shot is if they do have a tear or even a partial tear that might go on to have surgery because the infection rate can go up, the healing rate can go down, and and we know that, exactly.
At counsel, it's like, here's the deal. Sure, we could do it, but hear me out. Timeline-wise. So we've got to make a decision. It's like, again, bringing the patient in to their treatment plan.
Right. Will you, when you do the cortisone shot, do you suggest it as like, okay, you're hurting so bad, I got to kind of get that squared away so you can even make some meaningful gains in therapy? Is it like that bridge to kind of get things? Yeah, and that's what
I use it as. It's a bridge. I tell people, they're like, well, should I get it? I'm like, okay, here are my 3 things. Is it keeping you up at night? Can you not sleep because of it? Because if you're not sleeping, you're not healing. And is your mood being affected by it? Are people telling you you're being crabby?
and as the wife sits in the corner and nods.
Are you being crabby? Are people noticing, or are you finding that your mood is affected by this pain? Okay. And is it severely stopping you from being able to do what you need to do, i.e. work? Yeah. Or taking care of family members? Those are my big staples of like, okay, this is where, because especially if they're on the fence about it, people have fear of needles. Legit. I get it. I own one. I'm great on the delivering end, not great on the receiving end of needles, but those are what I use. I'm like, this is not fixing anything, so we do not have to do it. Right. It's not a have to.
Right. So, okay, so let's talk about PRP in maybe a little bit more detail in the time that we have left. So you said PRP stands for
plasma-rich protein.
Plasma-rich protein. And how I've also heard it like platelet-rich plasma. So as well.
Platelet-rich plasma. There's leukocyte-rich plasma-rich protein. I mean, there's a couple different varieties. This is where things get a little murky and why there's no like standard dose with this. This is where when you look at the literature, you really have to read what was used, how much was used, what equipment was used, and because there's so many variants, and that's why there's no consistency with the research. It's hard to say that you're comparing apples to apples when you look at like those looking at multiple studies at once.
And like number of injections.
I mean, some people say you do 1, some people you need at least 3. How long do you wait between them? How much are you giving? Are you giving the same amount on each?
Is it different for different parts of the body?
But it's like, what about this tendon? Or it's super fun.
Right. Yeah. So, how does a PRP like help the tendon?
Yeah, so again, I think of it this way, and it's a pretty elementary explanation, but I think of it this way. I am taking the body's natural healing cells and cytokines and all the goodness that helps with the healing process, everything involved with the inflammatory process. I'm taking those components at a higher concentration that would otherwise be delivered to that area and dumping it in that region, trying to help facilitate the healing process. I'm trying to utilize the body's own natural healing system to help with the problem.
And is it helping, like what we talked about at the beginning, where we have the type 1 collagen, the type
and that's
3?
That's what I'm trying to do.
Helping that
trying
process.
to snap it into a more productive healing process.
Right. And so in my reading, it seemed like the trend was towards the PRP working a little bit earlier in the process compared to like it's just totally chronically
right. Whenever you
worn
have
out.
like just it's all in disarray. There's no real true active inflammation going on anymore. It's just it's chronic. It's poorly built at this point. It's just slapped together.
Yeah.
But yeah, if you can catch it early in that acute inflammation phase, it's usually better because then you can, again, utilizing the body's healing systems to fix that acute problem that's already in the process.
Right. Okay.
Yeah.
And by acute, 6 months of symptoms?
Like weeks.
Okay.
Like weeks. And that's where it's tough because most people, their tendinopathy has been going on for quite some time.
Okay.
So think of your more like partial tears of the tendon. Like someone comes in, I felt it happened on this day, kind of situation there.
Right. Right.
Yeah.
So can you use, maybe they don't have like a traumatic acute onset, but can you use duration of symptoms to decide when
that.
PRP might be more effective?
I utilize that because again, with our overuse, it's just the chronic micro turning to macro injury. I use that too, but earlier the better. I mean, I wouldn't, because of the pain associated with PRP, because I mean, all those pain mediators are being dumped into that area too. I wouldn't do it 2 days after an injury.
Yeah, or maybe in season.
Or in season.
Yeah.
I mean, I would want them to have some time that I can truly rest them properly after the injection.
Right.
So, I mean, there's a few caveats, and again, it's pretty individualized how I go about it, and this is a discussion I have with the patient about success rates and what to consider.
Right. Okay, and then it lasts longer than a cortisone shot as well.
Yeah, it's showing.
On average.
Yeah. I mean, if you look at look at head to head with them. The short-term satisfaction, the patient's pain and function, sometimes cortisone works a little bit quicker, but we're looking for the long-term here. PRP is looking like it's a little bit better. But again, I say this with a huge asterisk, depends on the location.
Okay.
Depends on the location, where it's going, and depends on what study you read.
I gotcha. So where do you find it works the best?
I've seen success with elbow, so your tennis elbow.
Yeah.
And this is anecdotally, this is my practice. I've seen it successful with elbow. I've seen it work well for hamstring. And those are the ones I've seen it also work well for partial tears of patella tendons. I've seen a couple cases in my practice that I've had some pretty good results with that.
Gotcha.
Yeah.
Okay. I want to throw this in this last minute that we got here. When it gets really chronic and you have a big buildup of all those bad disorganized collagen, all that stuff, you can do the percutaneous ultrasound evacuation of the diseased tendon, which you need to get out, and then hopefully then it heals and where you can add
so
something.
it's a needle tenotomy, so you can either do it by needle or by device. There's different companies that you can use, but the purpose is to break up that buildup. So with a needle, you're not sucking it out or anything, but you're breaking it up so the body can naturally absorb it. So the macrophages can go in like Pac-Man and eat it all up.
Gotcha.
Okay. You just break it. I mean, that's what I think of when I see them
That's
under
good.
a microscope.
I
They look
like
like
it.
little Pac-Man. So
it.
I go ahead and they break them up. That's with the needle. And then there's devices where you can break it up with a needle, but it also has saline and suction. So it's taking all that gunk out, and you do it under ultrasound so you can actually see it being broken up. And if you use the device, you can actually see it getting removed in the process. There's some literature and some that have done it with PRP as well after the procedure. These are options that are out there.
So we're talking about, actually getting in there and removing the diseased tendon. We're talking about the much more chronic, long-standing type of problems.
Yeah.
And then for even further down the line, you're talking about surgical intervention for sure.
I mean, this is stuff that you would do after they have not made great strides in improvement with physical, the standard of care.
Right.
So the physical therapy, and activity modifications and adjustments with equipment that they're using, so on and so forth.
Gotcha.
Yeah.
There's a lot more other treatments that we could
goodness.
get into. Just don't have time to do it. You mentioned all the low intensity laser, high volume injections, glycerol trinitrite, topicals, shockwave therapy. It's just, there's just so many.
I mean, I read one that was like metformin getting injected in the area. I'm like,
Or
what?
topical metformin, yeah.
Yeah, I'm like, what?
Well, look, we'll have to save that for another time. I got to thank you so much for sitting
no
down.
problem.
We covered a lot of material, but I think this will help a lot of patients. So really, really appreciate it.
Yeah.
Thanks for coming on.
Thanks for having me.
All right. Thanks for listening, everybody.